Hello, everyone. Thank you for joining us today. I would like to start off by introducing ourselves and providing some brief insight into our background in the field of applied behavioral analysis. I'll begin. My name is Morgan Stiltner, and I will act as the introducer of the debate this evening. I stumbled upon the field of ABA a little over a year ago and have worked in a clinical setting as a registered behavior technician since. Our clinic provides ABA services to children around the ages of 2 to 10 years old, and I have had the great opportunity to work as the lead RBT for everyone for the past few months. This role includes training new staff, providing ongoing education on client-specific protocols, and giving both positive and constructive feedback to the BTs and RBTs. My passion for this field has grown tremendously since I started, and I cannot wait to further my knowledge in the field of ABA.
I
Hello.
am I next? I'm sorry.
It's okay. I'll go next, I guess. Hi, everyone. I'm Brittany DeVault. I've worked in ABA since 2015. I've jumped around small companies throughout the years due to moving for my husband's job. Currently in my third semester here at Ball State to get my master's in applied behavioral analysis. And I plan to sit for the BCB exam. I provided therapy in mainly clinic settings. I've dabbled in transitioning clients into a school setting, and really have found that I prefer a clinic setting. I worked with clients between 2 and 23 years of age, all across the spectrum. I have experience with high magnitude behaviors such as physical aggression, self-injurious behavior, and property destruction. I also have experience with our nonverbal learners, with American Sign Language. LAMP, for anybody who doesn't know, LAMP is the application that uses an iPad to talk for you, and also various forms of text. I've worked in settings where I have attended occupational speech, physical therapy, as well as feeding therapy. I found that very beneficial to understanding how an interdisciplinary team works. In my past two centers, I've had a lead behavior technician role where I train new hires and oversee them. And I have found that I absolutely love to do that and would love to continue training the next generation of great RBTs.
I guess I'll go next. Hi, everyone. I'm Jenna Burrock. I have been working in behavior analysis since 2021. I kind of got this job by accident. It was just something to do, and I fell in love with it. Um, I've currently am working in rural Kentucky. We currently serve clients from 2 to 6 years old, but my experience is in anywhere from 2 years old to up to 16 years old. Um, and I have also assisted in speech sessions and also feeding sessions with clients. And I found that that has really helped my understanding of how to collaborate and utilize behavioral skills in tandem with the other disciplines. Um, I'm currently getting my master's in applied behavior analysis and here at Ball State. And I look forward to sitting for the BCBA exam and hopefully becoming a behavior analyst.
And I will go next. My name is Vanessa Cornelius, and I am acting as the facilitator of this debate. I have worked in the field of ABA for roughly 2.5 years. I also kind of stumbled upon this job. I saw someone in a daycare setting providing ABA services, and that really intrigued me. Currently, I work in a clinic where I serve as the programmer and student analyst, of course. So I just kind of help out with the BCBAs and then modify any plans as needed, and then observe the other RBTs as well. And I have been collecting IOA data and stuff, so really just getting all of the training needed to become a BCBA. I've worked with clients as young as 2 and then as old as 20 years old, and then had behaviors ranging from super mild to severe, also including any like self-injurious behaviors, property destruction, and aggression. Something I wanted to make note of, this debate has been super beneficial to me, especially because I work in home once a week with a client who has an occupational therapist and a speech therapist come. And I'm supervised by my BCBA like 2 hours of that session, but I'm still there having to collaborate with these other professionals. So this has really like helped me grow and like understand how important it is for the client's sake to be able to collaborate with other professionals.
Hi, I'm Victoria Parrott. I will be the summarizer for the debate. I am currently in my master program in hopes of becoming a behavior consultant. I started my journey out early. I started working with people with disabilities when I was in high school. We had a classroom where we could go in and be like a peer tutor, and then we could just walk alongside them throughout the school day. And then I actually got hired at the high school once I graduated, and I worked there for 6 years. I gained a very strong knowledge towards the field. We had a lot of really aggressive behaviors that were very challenging day by day, but definitely taught me a lot. I switched to a residential facility as the community living house manager and QDP. So I basically just oversee the medical, housing, finances for 32 clients that live in the community. I have clients ranging from 8 years old to 72, and they have a range of disabilities. I do have experience with mild to severe behaviors and work with a team of people to help the client live their best life. I've attended many training courses within my company, and the most recent being Leadership Academy that I recently just graduated from. And my passion for this field grows daily, and I cannot wait to graduate and continue with my lifelong goals.
Thank you for each of your thoughtful introductions. Now, our group will be conducting an informal debate on the topic of collaboration with other professionals in the field of applied behavioral analysis. The points we will be diving into include relevant BACB core principles and ethics codes, a brief background in ABA, the Broadhead model, the pros and cons of collaborating with other professionals, and some Q&As. Before discussing our topic, we would first like to introduce relevant core principles and ethics codes that apply to our debate.
Our applicable core principles include the benefit of others and ensuring our own competence. Behavior analysts work to maximize benefits and do no harm by effectively and respectfully collaborating with others in the best interest of those with whom they work, and always place clients' interests first. When we ensure our competence as a BACB or a BCBA, behavior analysts ensure their competence by being aware of, working within, and continually evaluating the boundaries of our own competence.
Thank you, Brittany. So in addition to the core principles, I'm going to discuss the 3 ethics codes we found to be the best fit for collaboration with other professionals. So it is 1.05, practicing within the scope of competence. And essentially that code explains that behavior analysts practice only within their identified scope of competence, and they engage in professional activities in new areas only after assessing and documenting appropriate study, training, and supervised experience, consulting, and co-treatment from professionals competent in the new area. Otherwise, they refer or transition services to an appropriate professional. The next code is 2.01, which is providing effective treatment. So behavior analysts prioritize clients' rights and needs in the service delivery. They provide services that are consistent with behavioral principles based on scientific evidence, and they're designed to maximize desired outcomes and protect all clients, stakeholders, supervisors, trainees, and research participants from harm. Behavior analysts implement non-behavioral services with clients only if they have the required documentation, formal training, and professional credentials to deliver such services. And then the final one is 2.1, which is collaborating with colleagues. So behavior analysts collaborate with colleagues from their own and other professions in the best interest of the clients and stakeholders. Behavior analysts address conflicts by compromising when possible and always prioritize the best interest of the client. We will also be documenting all actions taken in these circumstances and their eventual outcomes.
Thank you both for sharing. Now that we have reviewed the relevant core principles and ethics codes applicable to our debate, Victoria is going to take the floor to discuss what exactly ABA is.
So to start, discuss exactly what ABA is. ABA is known as Applied Behavior Analysis, which is a scientific discipline that implements evidence-based interventions with the objective to improve socially significant targeted behaviors. ABA is primarily used for individuals with autism spectrum disorder and developmental disabilities, such as ADHD, and works to better prepare these individuals for the real world in socially important settings. Socially important settings include, but are not limited to, the ability to form friendships in the public, focusing and learning in school, as well as finding a place of employment. Each of these are inevitable situations that everyone encounters in life, and the ABA aids in equipping individuals with the tools necessary to provide so they can confidently face these challenges. In recent years, the field of ABA has grown tremendously, and the demand for behavior analysis continues to steadily increase as the diagnosis of autism spectrum disorder has become more prevalent. With such demand, the idea of collaborating with other professionals has been a permanent topic of discussion. Many individuals diagnosed with autism spectrum disorder obtain services from various non-behavioral professionals alongside behavior analysis, such as speech language pathologists, occupational therapists, psychologists, and pediatricians. These services can also be provided in various settings, including schools, clinics, in home, and in hospitals. Our informal debate is going to address the benefits of collaboration, as well as the barriers that could impact effective collaboration among other non-behavioral professionals. Next, let's go over the basis of our discussion today.
Our debate topic is centered around an article written by Matthew T. Broadhead called Maintaining Professional Relationships in an Interdisciplinary Setting, Strategies for Navigating Non-Behavioral Treatment Recommendations for Individuals with Autism. In his article, Broadhead describes the benefits of working within an interdisciplinary setting with non-behavioral professionals, such as enhancing the quality of services and expanding one's scope of competence while protecting the well-being of clients. Although there are many advantages of collaboration, there are also some drawbacks to this, including how time-consuming it can be, financial considerations, and ethical concerns. Thus, today's debate will discuss both the advantages and barriers of collaborating with other professionals.
Just to go over the Broadhead model in his article, Broadhead proposes his model. The Broadhead model is a decision-making model created to guide behavioral analysis when evaluating whether to implement a non-behavioral treatment. It also aims to maintain an ethical balance between professional relationships and the well-being and safety of the individual with autism spectrum disorder. This can be a useful tool to utilize when working alongside non-behavioral professionals, as it provides an easy step-by-step guide to follow regarding addressing non-behavioral treatment. As you can see from the model, it ultimately leads to the decision to address or not to address the treatment. This model will be an important aspect of our debate. Now let's go ahead and dive into it.
Jenna will start off the discussion presenting some of the advantages of collaboration with other professionals.
Thanks, Morgan. So, following the Broadhead model could lead to an increase in socially significant goals created across disciplines. So, this might look like a learner focusing on increasing vocal requests in replacement to maladaptive behaviors within the ABA therapy setting, but a speech therapist would be focusing maybe on the pronunciation of vocal requests, of those vocal requests. Maintaining scope of competence and practicing within our scope is pertinent to providing effective therapy. Broadhead reminds behavior analysts that although ABA is this younger field, um, relative to other disciplines, our principles and techniques within behavior analysis are evidence supported. This does not mean that SLPs or OTs do not utilize evidence based practices. However, the lens which our goals are prioritized may differ based on discipline. Last but certainly not least, ensuring client well-being and safety is of utmost importance for all members of our client's treatment team. And if the treatment goals are selected that interfere with the reduction of the maladaptive behaviors within the ABA therapy space, we as behavior analysts would have a responsibility to provide effective treatment, and this would require collaborating with pertinent professionals and stakeholders. Having a discussion with the other professionals or the treatment team is necessary in resolving this issue or brainstorming possible solutions to remediate the interference, but also work towards relevant goals. Sometimes this may indicate that a learner is not behaviorally prepared for a least restrictive setting, such as speech or occupational therapy. The Broadhead model describes key factors of collaboration and allows behavior analysts to have a systematic manner to determine when analysis of non behavioral treatment is necessary. In addition, this collaboration allows for the ability to learn and gain knowledge across disciplines from people of varying cultures and background, which leads to a better outcome for our learners.
Thank you for your input, Jenna. To add to your point, collaboration with other professionals provides a unique opportunity to expand both a behavior analyst's scope of competence and scope of practice. BACB Ethics Code 2.01, providing effective treatment, states that behavior analysts can implement non-behavioral interventions if relevant training is acquired. There are many ways to acquire such training. For example, you can attend international conferences and conventions, complete additional CEUs, read literature, further your coursework, and undergo supervision directly with non-behavioral professionals. Not only does this allow behavior analysts to further their knowledge in specific areas and create a broader social impact, but also gives them a chance to expand their network and list of resources to provide future clients with. Before we dive into the other side of the debate, let's jump into a couple of relevant Q&As. Our first question will be for Jenna. How does one gauge their scope of competence accurately?
So, practicing within scope of competence is very important for us to be providing effective treatment and maintaining our clients' well being. In ABA, for example, our scope of competence is measured based on our credentials obtained. Um, we have BCBA, BCBAD, and RBTs. So, for example, all of us on the call want to be a behavior analyst of some sort. And this would require us to obtain an undergraduate degree, complete our master's degree, complete 2,000 fieldwork hours under the supervision of a already certified behavior analyst, and pass the board exam. And complete continuing education credits once we are a behavior analyst. Completing those steps allows for the BCBA to complete functional analyses, select behavior change procedures, among other abilities and privileges. Also, a behavior analyst will obtain a licensure from the state in which he or she is practicing, which comes with laws and regulations that he or she must follow. Our scope of competence is determined based upon our experiences, our educational background, and other certifications obtained by the BCBA or the professional. If a BCBA does not have the additional training that is necessary in a certain area, he or she should obtain additional feedback from another professional, should look to obtain trainings, or look to complete any necessary degrees or other certifications required to administer that type of therapy.
Thank you for your informative answer, Jenna. Our next question will go to Brittany. How does one increase their scope of competence in other areas?
So I found a really good article by LeBlanc, the 2012 article by LeBlanc that identifies avenues to increase someone's scope of competence. So the first step is going to be finding the relevant material, literature, whatever that may be. This article referenced JABA, the Journal of Applied Behavioral Analysis. PsycInfo, PubMed literature is really good. Looking for relevant handbooks associated with the intervention that you are unfamiliar with. Another step will be finding professional groups that are associated with expanding your scope of competence, such as becoming a member of an association that's pertinent to the target intervention or audience. We're also pursuing extra training in other areas. One way that LeBlanc suggests is finding a mentor. One last avenue that is of utmost importance would be to identify any necessary credentialing you would need to obtain before doing expanding your scope of competence or considering doing a non-behavioral intervention. Make sure that you are credentialed appropriately.
Thank you, Brittany. So we have heard about the benefits of collaborations with other professionals, but what about the obstacle it poses? Next, we will dive into hurdles associated when working with other professionals. Brittany, you may begin your side of the debate.
Okay. So when working with other disciplines, our duty is to keep all of our stakeholders informed. We're looking at significant time commitment to coordinate services, funding concerns for continuous training or education. We're running the risk of ancillary therapies, possibly asking for BCBAs to adopt and implement their interventions. Also, ABA is a relatively young field as compared to PT, OT, ST. We'll see in the next couple of slides. So they have quite a bit more, let's be honest, they have quite a bit more research associated with them and a lot more time, trials, all of that to pick them up. So here we're talking about the time commitment and the funding concerns. So again, like I said, our duty is to keep all of our stakeholders informed. When other therapies occur during ABA services, there is a disruption to the typical flow of your therapy session, and it could detract away from the behavioral services that you're providing. This would force us as clinicians to not provide the best behavioral services that we can. As to the training and funding concerns, I'll touch on that in the next slide. Move that so we can see. Okay. So now we're going to talk about the ancillary therapies that we touched upon before, the OT, PT, ST, and how ABA is a relatively younger field. So to touch on the main three that we commonly see with our field, our cohorts in those other fields have training in kinesiology, physiology, acoustics, training that us as BCBAs or BCs will not receive without great effort or cost. Referencing the coursework for IU's Doctorate of Occupational Therapy, students in their first semester have a course that covers joint structure, and biochemical principles. For Ball State's Master in Speech Pathology, their courses cover neurogenic disorders and audiology. And then as far as the physical therapist program at Indiana University, they receive training in areas such as clinical pharmacology and functional anatomy. Their interventions are implemented with thorough background and training to the human body and biology, which would fall under being outside of our scope of practice and therefore scope of competence. Since our clients spend a great deal more time under our care, there is the risk that these therapies would feel as though there are more opportunities for their clients to come into contact with the ancillary intervention, with us having more time with them. However, we are overwhelmingly untrained in their methods, and it would be unethical for us to implement any strategy, however tempting or well-meaning from them. And ABA is a relatively young field. As compared to our commonly associated cohorts, as you can see from the timeline in the bottom right, the associated accrediting bodies for each discipline is listed. With so much more time for research, implementation, feedback, and reworking of interventions, those used by other professionals may have a longer history. Although successful as referenced by the massive differences in topics that are covered in our education, we would not readily understand the history, the significance, and the nuances of those interventions that they are implementing.
Thank you, Brittany. Now that we have addressed both sides of our debate, Vanessa is going to lead us into a couple more Q&As. Our first question is, what are common barriers or misconceptions when collaborating with other professionals?
So I've highlighted 2 points for this question. One is lack of evidence-based practices, and then the second is interactions with others. So for lack of evidence with other professionals, a common misconception that affects successful collaboration with others was that BCBAs function or think like, oh, occupational therapists are not implementing evidence-based practices. But the rebuttal to that misconception is that occupational therapy, they have a discipline listing that outlines all of the services that they provide and how evidence-based practices are really important to them for their line of service. So moving forward, the interaction section, one barriers was that when BCBA is working with occupational therapists and speech therapists, there are often disagreements among them regarding treatment and then the goals that they are choosing. And then in addition to that, there's also disagreements regarding who believes they should focus on that specific deficit or intervention based upon their own previous knowledge or education. So they kind of like hit heads there. I did find an article by Welch and Poljaco in 2016. They discussed professionals outside of ABA viewing it out as a service where we just place instructions or demands rather than being the specific evidence-based practice that we implement. And then other professionals outside of ABA, they believe that we do not plan to have skills generalized and that it's not client-based. However, that is just inaccurate, or it serves as a barrier, which kind of makes it hard to collaborate with other professionals.
Thank you, Vanessa. The next question for you is, how can you improve collaboration for optimal outcomes?
So I found another article, and this is by Giskweski and others from 2001. They offered insight into collaborating with other professionals, and they suggested actually abiding by the ethical codes of the respective disciplines. So looking at occupational therapists' ethical codes and then speech pathologists as well. They specifically discussed BCBAs working with occupational therapists and explained that both fields have stressed the actual need for using evidence-based practices. And then moving forward, to ensure that the best outcome is achieved, all of the professionals that collaborate together must keep clients as their main priority and then avoid harm at all cost, of course. And then the last thing I wanted to touch base on, which I think is extremely important, is being able to communicate. That was such a big factor in collaboration with other professionals. So the same article recommended evaluating the interventions proposed as necessary, also including the review of evidence based around those interventions that are proposed, and then communicating with the other professionals in the field whenever changes are made, whenever discontinuation of a specific intervention is no longer being implemented, as it aids in providing the best outcome for the client at all times.
Thank you again, Vanessa. Now that we have addressed both the pros and cons of collaboration with other professionals within the field of ABA, as well as addressed relevant Q&As, let's conduct a group vote. Vanessa, you can go first. What will your vote be?
I am pro Broadhead.
Thank you. Brittany, you can go next. Okay, thank you. Jenna?
I am pro Broadhead.
Thank you. And Victoria, you may go ahead.
I'm pro Broadhead.
Thank you. As for my vote, I will also side with pro Broadhead. Now that we have each agreed upon, now that we have each agreed that pro Broadhead is the winning side of our group debate, Brittany will wrap up our discussion by providing a conclusion.